And how are you employed, sir?
I'm an orthopedic surgeon.
Okay. And where do you live?
I live in California.
Okay. And are you married?
I am.
And do you have children?
I have 3 adult children.
Okay. Do you have any grandchildren?
I have 7 grandchildren.
Okay. And you have one child that lives close to us here in Georgia. Is that correct?
I have a son who moved to Tennessee a couple years ago, just across the border.
And are you currently employed at a hospital in California?
I am.
And what hospital is that?
That's,
Okay. And what do you do?
I'm the orthopedic trauma surgeon.
Okay. And how long have you been there?
I've been there since 2015.
Okay. Let me go through your education and training history for just a moment, okay? Where did you go to college, undergrad?
I went to Pacific Union College in Northern California. It's in the Napa area, just north of San Francisco Bay Area.
Okay. And did you earn a degree from that college?
Yes.
And what was your degree in?
It was a Bachelor of Arts.
Okay. And from there, where did you go in terms of education?
I went to Loma Linda University School of Medicine.
Okay. And when did you graduate from that school?
I graduated in 1973 from the School of Medicine.
Okay. And did you continue your education after Loma Linda?
I did.
Where did you go next?
Well, then I took a year's internship at Florida Hospital in Orlando, Florida. And then I took a 4-year residency in Southern California in Los Angeles in orthopedic surgery. And I took a spine fellowship in orthopedic surgery at USC, University of Southern California, at Rancho Los Amigos, which is the big rehab hospital in Southern California.
Okay. And are you licensed in any state to practice
Yes,
medicine?
I'm licensed in the state of California.
And you mentioned a moment ago, and I think there's some terms that get thrown around, and sometimes we're, as lawyers, probably a little bit neglectful in assuming that folks know what some of this stuff means. You said that you completed a residency at a hospital. What does that mean?
Well, after graduating from medical school, you have to spend a year on-the-job training. That's called the internship. And then you can take the test to get a license, and then you're a practicing physician. You get a degree as a medical doctor after graduating from medical school, but you don't have a license. And so after having a year of hands-on training called an internship, then you can get a license. But to have a specialty as a surgeon or as an orthopedic surgeon, then it requires further on-the-job training. That's what a residency is.
And orthopedic, what is an orthopedist? What does an orthopedist do?
Ortho means bone, and pedic means children. But actually, an orthopedic surgeon is a physician that takes care of bone and joint problems.
Okay. And you are board certified as?
I'm a board certified orthopedic surgeon.
How does one become board certified?
Pardon me?
How do you become board certified?
Well, you have to meet certain minimum requirements, which, they schedule a residency so that you have so much exposure to children's fractures and so much exposure to tumors and so much exposure to adult reconstructive problems and spine problems. And so it's a regimented, prescribed course so that you have certain minimum requirements, and then you sit for a oral examination, and they ask questions, and then there's a written test as well. So it's a process.
Have you completed, after your education, your formal education, any fellowships?
Yes.
Where were those?
That was at Rancho Los Amigos in spine surgery. And then after 2000, I took a fellowship in pelvic and acetabular reconstruction.
And was that in California as well?
That was in California and Seattle. It wasn't a formal fellowship. It was an informal fellowship because I was retired actually, and I became interested in trauma, and I started doing trauma in other countries, and I was invited to spend time with two of the most prominent pelvic and acetabular surgeons in the world. And so I would fly down to Los Angeles or fly up to Seattle and scrub with them. So it gave me an opportunity to be exposed to something that's a very specific type of surgery.
Have you worked abroad outside
have.
the United States? Where have you worked?
Well, when I was medically retired in 2000 from an injury, an orthopedic injury, and it wasn't thought that I would return. And so I retired, but I had an unexpected recovery. And I began working in Afghanistan, in China, and Brazil. I've been to the Dominican Republic. I've been to Haiti. And it was on those travels that I became aware of metabolic bone conditions, from malnutrition, from starvation, from different genetic factors, from deficits. And that caused me to become interested, and I've began the process of studying for things that I had never paid much attention to before, and if I had seen it, I wouldn't have recognized it.
Have you founded any nonprofit agencies?
I did. My wife and I started a nonprofit foundation called the Foundation for the Study of Metabolic Bone Disease.
Okay, and when was that founded?
You know, I think that was probably 2013 or 14, and it funded research mainly at Johns Hopkins.
Have you consulted in your years of experience on cases involving infants and fractures of infants in the past?
I have.
And in what capacity have you consulted?
As an orthopedic surgeon and as an expert in metabolic bone disease.
Have you been tendered and admitted in court as an expert in those fields?
I have.
Approximately how many times, do you know?
I think this is probably the 9th or 10th time.
And you have testified in trials before as an expert, is that correct?
I have.
Judge, at this time I would tender Dr. And ask the court that he be allowed to give his opinion in the field of orthopedics and metabolic bone disease.
Ms. Bernard, any objection?
No, Your Honor.
Ms. Fox, any objection?
May I cross on his qualifications?
You certainly can.
Mr. You've given us an extensive history as your experience in orthopedics. I want to ask you specifically, you are not a radiologist?
I am not, but I read x-rays pretty much every day that I do orthopedic surgery.
You did not go through the additional training that a professional radiologist would go through to get certified to read those x-rays, though, did you?
I do not, but I do go, I have, as part of my training, gone to courses that were specific for radiologists, but part and parcel of my everyday work is reading and interpreting x-rays, and that's a part of orthopedic surgery.
When you do surgery as an orthopedics, you would work alongside a real radiologist, though, wouldn't you? They would read the x-rays in any legitimate hospital.
We work in the same hospital, but we don't work alongside each other.
Okay. You are not certified as a pediatric radiologist either.
I am not.
You've never done a fellowship or internship in either radiology or pediatric radiology.
I have not.
And you do not have a degree in genetics?
I do not have a degree in genetics.
Have not gone through any fellowships or internships in genetics?
I have not, but I was the top of my class in genetics in college. Actually, I was tied for top of my class.
I was top of my class in wills, but I wouldn't write a will 35 years later. Okay, that said, I want to ask about the 9 times you testified. Has that all been recently or during the course of your career?
That would be since, I think, 2012.
Has it all been because of your hobby and interest in this field?
Yes, it's been, it started with an interest in unexplained fractures.
Okay.
And then as I studied that, I became more interested in metabolic bone disease because that's a significant part of it.
And have you only testified for the defense?
I have only testified in court for the defense, but I've been retained by the Department of Defense, and I've had 2 prosecutors call me and consult with me.
Okay. But you've only testified in court as a defense witness?
That's correct.
Okay. You indicated that you read scans as part of your orthopedic practice. Would that have been in California then, as your employment through the hospital, as you had mentioned?
Would you say that again?
You said that you have read scans as part of your practice. Would that have been in California as part of the hospitals you were affiliated with there?
I didn't understand the part you said. I had read scans.
Right. As part of your questions to me, or
Yes.
answers to me, you were indicating you've read films, x-rays. Was that part of your medical practice in California?
Absolutely.
Okay. And in that context, did you testify about any of the scans you read, or were they having other people testify about those scans?
Well, both. But I also have a license in California as an X-ray supervisor and fluoroscopic operator.
Okay. So the person that works the machine?
Pardon me?
The person that works the x-ray machine?
Yes, in California, many states don't require it, but in California, in order to operate an X-ray machine, particularly a fluoroscopic X-ray machine that is a moving machine that has high resolution and puts out a lot of radiation, you're required to have a separate license. I have that license.
Okay. So the bottom line is you are certified and licensed as an orthopedic surgeon, and you've taken tests and passed them in that field. You've never taken any test and passed them in the field of radiology.
No, but part of the orthopedic examination and board examinations include x-rays. That's an important part of it.
What percentage of that exam is specifically towards x-rays?
I would say probably 30 or 40% of every case involves x-ray interpretation.
Your Honor, that would conclude the questions on behalf of the state.
Thank you, Ms. Fox. Any objection to this witness? No. Then, Mr. Hood, pursuant to your request, this witness will be admitted as an expert in the field as requested.
Thank you, Judge. All right, Doctor, I want to ask you about some terms that we're going to be discussing during the course of your testimony this morning, and see if you can give a brief outline or definition of some of these terms, okay? When you talk about the study of bones, what exactly are our bones made of, and how are they formed?
Our bones are a reservoir for calcium and phosphorus. 99% of the calcium and the phosphorus that we have in our bodies is in the bones. And we tend to think of bones as the structure that supports us, and it is. But the reservoir is probably more critical to life because the phosphorus produces the energy that makes possible the 1 billion biochemical reactions that take place every second in every cell. And the calcium is a critical component of brain function, of nerve biochemical, electrochemical transmission, of clotting factors, of the conduction of your heart. So if the calcium is not carefully regulated, you die.
Do our bones contain a substance called collagen?
Yes.
What is collagen?
Calcium is an element, it's a mineral, And actually, it's one of the more difficult things for us to digest. And we have to have that, particularly during periods of growth, because as we grow, we need more raw materials. If you didn't have the raw materials, you couldn't come up with the final product, and you would be either stunted in your growth, or in the case of calcium, you might not survive because the biochemical reactions necessary for life itself wouldn't have enough calcium to function.
Okay. What about collagen?
Cartilage.
Collagen.
Collagen. Collagen are microfibrils that make up the structure of bone. We don't see them, but if you were able to take away the minerals in bone and you looked at them with very high-powered magnification or electromicron magnification, you would see what looked like ropes. And that is collagen, but that substance is also true in blood vessels, in skin, in ligaments, in tendons, and that's an important part of our soft tissue, but it's a critically important part of bone structure.
What is vitamin D?
Vitamin D is not a vitamin. Vitamin D is a hormone. And the difference is that a vitamin is a chemical element that's necessary for biochemical reactions that the body either can't make or can't make enough of. Vitamin D, the hormone, was initially thought to be a vitamin because it had the appearance of a vitamin when they looked at it superficially. And they've never changed the name. So when we talk about vitamin D, it's not like vitamin A or vitamin C, which is an element that the body depends on you to ingest in order to have it available. Vitamin D, the hormone, had that appearance when they looked at it superficially, but we think of it as being critically important in terms of controlling our body's ability to absorb calcium, which is difficult to absorb and requires certain conditions, but it requires vitamin D in order to boost the absorption from, say, 15% to 85%. And that becomes extremely important when you have growth factored in, because an infant doesn't have the same reservoir of minerals, of calcium and phosphorus, that they will have later in life, because the metabolic machinery is already running near red line, because they're doubling their birth weight in 3 months. And so, and they're growing inches in that 3 months. And in the first year, they will double their length. So the bone is not just necessary in terms of structure, but it's critically important as a reservoir for these minerals that are constantly moving in and out in ionic form in order to support heartbeat, electrochemical functions of the nerves, of the brain, and to control the clotting mechanisms to keep your blood in balance so that you don't have blood clots and plug things up, or so that you don't just spontaneously start bleeding, which can happen.
What is the effect, in your experience, on deficiencies in vitamin D and bone formation or bone development?
Well, worldwide, 100 years ago, there was considerable interest. Many, many books were written about vitamin D in the 20s, the 30s, and the 40s. There's not so much written now.
But Hold on just a minute.
I'm going to object to any literature that might be referenced or quoted by this expert. We were not allowed to do that on behalf of the state. I'm going to object to it on behalf of the defense trying to do the same thing.
Mr. Hood?
I don't think he was about to quote any literature. I think he was just making a point, but
So I think the objection was to quoting from the literature. I'll sustain that objection, but he can certainly reference that he reviewed literature. That's not a problem for him to do that.
go ahead, doctor. You were talking about books that were written about vitamin D in the 20s, 30s, and 40s.
Well, historically, there was a lot of interest because the hormone vitamin D was identified first as a vitamin when we know that it's a hormone about 100 years ago. And there was a lot of interest then, and there were a lot of studies that were being done. There's not so much now, and there's hardly a chapter or two in the pediatric textbooks or in orthopedic textbooks about vitamin D, the hormone, which is very different than 100 years ago. And the National Institute of Health puts out bulletins every several years that tells us that there's still a silent pandemic.
I'm going to object to what these bulletins are saying. We were not allowed to do that on behalf of the state. I would object if they are doing that on behalf of the state.
Mr. Hood, any response?
I'll direct him.
Okay,
away, Judge.
just rephrase your question.
So a lack of vitamin D or a vitamin D deficiency in, let's say, an infant, what is the effect of that on bone development for that infant?
Well, we know that vitamin D, the hormone, has much more than just the vitamin-like action of absorbing calcium, which was the first thing that it was identified for. There are, I think, 3,000 enzymes we know now that are affected by the hormone vitamin D. But as far as just bone, it interferes with the absorption of calcium, and I'll be able to show you on x-rays pretty clear manifestations of what happens when there's inadequate early mineralization.
Regarding this case, this involves an infant child by the name of Jamison Timms. You have been provided records and images regarding that child, is that correct?
Yes.
And have you had the opportunity to review those?
Yes.
And we've got some images that we're going to show, and we'll walk through those momentarily. But in the big picture, what did your review of the records and these images of Jamison demonstrate to you?
Well, in reviewing the records, the medical history, and the course of events, it was clear this was a medical mistake in terms of the diagnosis.
And what do you base that on?
I base that on the x-ray findings and the consistency of the story and how that fits with what I see on the x-rays and the lab.
Specifically, let me start with, there's an allegation in this case that there is a fracture, a vertebral fracture at T10. Are you familiar with that?
I am.
Have you had the opportunity to review the images that would purport to show a vertebral fracture in this case?
I have.
Have you formed an opinion about whether or not they demonstrate a vertebral fracture?
I have.
What is that opinion?
Well, as I recall, that was initially missed in the medical evaluation by the radiologist and by everybody who saw that x-ray. It's not surprising because it's a minimal difference in terms of the height that would be expected of that vertebral body at T10. So it's first of all, it's a very minimal, less than 1/10 of an inch difference in height from what you might expect as you progress from the upper part of the thoracic spine down, each body's expected to get a little bit larger. That's just what we're accustomed to seeing. In this case, T10 is not quite as large as you would expect, but it doesn't look like a fracture. I see fractures all the time.
What would you expect to see if you were going to call what you see on one of these images a fractured vertebrae?
Well, usually with a compression fracture, there's some wedging. There's one side, either the front, it's not symmetrical. In other words, it's not just a loss of height that's uniform. It's one side more than the other. Sometimes you can see some dimpling or breaking of the structure of the sides of it or the front of it. That's not present here.
Is the loss of height in this vertebral body, is it significant in your opinion?
No, it's structurally insignificant.
Do you have an idea or an opinion as to what would cause or potentially cause what you're seeing on these images?
Well, I remember my board examination had a picture of I think it was T10, that also had one that was much more involved in this, and the correct answer was histocytosis X, which is now called Langerhans cell histocytosis. That's an accumulation of cells that are scavengers in the body that take down old tissue, and for reasons that nobody understands, there will be a concentration of those in a thoracic body, and they actually consume enough bone that the bone symmetrically loses its height, unlike a fracture, which tends to be more of a wedge deformity, either to the front or to the front and one side. But in this case, there was also a lab value that I've noticed that didn't fit as far as trauma.
And what lab value is that?
Well, that's lyspace. And as a trauma surgeon, I've noticed that my patients that have trauma, particularly in the upper abdomen, and this happens to be, we'll see on the x-rays, the pancreas, which produces lipase, which is a very powerful enzyme. It resides and lives just below the diaphragm at T10. So if you were to have sufficient trauma to even cause a minimal or even insignificant loss of height, as we see in this case, the lipase should be elevated. And I would expect it to stay elevated for a couple weeks, because that's what I've seen. In this case, it was abnormally low.
And specifically, the higher lipase level would be caused by what? Damage to which organ?
The pancreas is very sensitive, and one of its responses to stress or an injury is to produce lipase and amylase.
There's also an allegation in this case, doctor, of non-accidental trauma to 3 left posterior ribs. Are you familiar with that?
I am.
Have you had the occasion to review the images related to those ribs?
I did.
And have you had the ability or have you formed an opinion as to what you see on those images?
Yes, I have.
Okay. Tell me what you see, and then we'll talk about your opinion as to what may have caused it.
Well, the rib fractures, I think it was 8, 9, and 10 on the left side, are clear evidence of a inadequate metabolic bone early on in life. And that is because other cases that I have seen that I've found x-rays that confirmed a fracture at birth shortly after delivery. It's expected that because of the rapid growth, an infant will repair the bone and remodel the bone and not leave any evidence even that there was an injury to the bone from the birthing process, which confirms for me in multiple cases that these are birth-related from the passage through the birth canal. And this callus, or the attempt of the body healing it, is clear to me in that it's too much and it's poorly mineralized. And that confirms, along with the other bone findings that we'll see in a minute, that this is metabolic, that these are birth-related fractures, and what they're seeing and thinking are weeks old actually date back to birth. So for me, it's a confirmation of the other bone findings, that this is not trauma that's related to something that was inflicted.
In your experience as a physician, as an orthopedic surgeon, can I safely presume that you have dealt with a wide range of trauma in your practice?
I have.
Can you give us some examples briefly?
Well, fractures and trauma, we usually consider them generally and on the basis of how much soft tissue damage there is, because the bones hold us up. But if you have a fracture, it's non-functional. The structure has been defeated. And the most severe would be traumatic amputations, because the bone and the soft tissue has been completely separated. And then there would be open fractures where there is so much damage that the soft tissue is torn along with the bony structure. And then there are closed fractures where the soft tissue is still intact but maybe beat up, and maybe the bones have done a lot of damage, but they haven't penetrated the covering of the skin. And then there are simple fractures where there's not as much soft tissue damage. And then occasionally in trauma, we'll get a fracture that has a crack with no damage that's visible to the covering of the bone, and very little, if any, damage to the soft tissue envelope around it. And the difference between traumatic fractures of normal bone and metabolic lesions of the bone that we call fractures, kind of like we call vitamin D a vitamin when it's really a hormone, those are really evidence not so much of trauma, but of the metabolic process that resulted in the bone being weak enough that it could fail. And those, unlike the trauma-related fractures, tend to be undisplaced, meaning there's a crack, so that unless you have the x-ray aligned at just the right angle, you won't see it. Or there's very little, even the tube of soft tissue that covers the bone, the lining of the bone, may not be damaged. And so the structure can actually still support the weight of the limb. And so it doesn't have the looseness of an unstable fracture, but those are common in metabolic lesions, but pretty uncommon in my experience in traumatic injuries. So that helps to separate these things out. For instance, these 3 rib fractures were all probably cracks, because we can see the line of the ribs and it's perfect. They're lined up just like railroad tracks. They're parallel, there's no offset, there's no tear in the soft tissue or the lining around them. And so that's not consistent with the world that I live in, the trauma that I see.
If you dealt with a patient that presented, even a small child, with three posterior rib fractures and a compressed vertebrae, would your experience tell you that you would expect to see, if the cause of that was non-accidental trauma, some intentional force applied to the child, would you expect to see other injuries in addition to fractures in bones?
You would.
And what would you expect to see?
Well, if 3 fractures is that suggests a significant level of trauma in the trauma setting. I mean, a baby can't talk, so it can't tell you when it has pain, but a baby can tell you that it doesn't like something. And if a baby has pain and you're attempting to start an IV on it, it takes 2 people. One person has to hold them and hold the extremity steady while the other one tries to put a needle in a very small vein. The baby tells you that it's not happy and that it's hurting, and it reacts to pain. And so, even though we depend on the history of people, a baby that had 3 traumatic injuries from being in a bad car accident, perhaps, or the one baby that was the only survivor of an airplane accident several years ago, it would tell you, and its vital signs would tell you, that it had been traumatized. It's nothing like this, where the amylase and the lipase would be abnormally low.
Would you expect a child who had been subjected to that sort of trauma to be described by the treating physician as a clinically well child?
No, that's consistent with the bone finding. This is metabolic, and it's a misdiagnosis.
Did you notice anything in the records that indicated that there was any chest wall injury to this child?
There were not.
With these types of fractures, rib fractures, and an alleged compressed vertebral fracture, would you expect to see some evidence of injury, soft tissue injury around the chest wall?
Absolutely. You don't have multiple rib fractures, 3 or more, from a trauma setting. Those are considered, evidence of a significant impact. But when you have the X-ray findings, as in this case, they're consistent and they refute that.
What, in your opinion, would have caused these rib lesions?
Well, I'm sure that the rib cracks happen from the birthing process.
Okay, what happens in the birthing process that would cause rib fractures?
Well, we're all here. Most of us were delivered without a C-section, but I have seen rib fractures in newborns, even from babies that were delivered by C-section, because the uterine contractions have an amazing amount of force. The reason I know that is, as a pelvic surgeon, I have seen women who, during the birthing process, had their pelvis dislocated by the force involved of the baby's body resisting the passage through the mother's pelvis to the point that the mother's pelvis failed. We consider that a major traumatic injury and trauma. It takes a lot of force, like 100 times more force than the strongest man in this place could squeeze. Those are the compressive forces. So that's why I'm very confident when I see an infant with posterior rib fractures, particularly those with failed healing and callus that doesn't have much mineral in it, that those are birth related.
All right. Your Honor, can I ask Dr. Step down, and I'm gonna try to position the easel so that everybody can see it.
I tell you what we're gonna do. We're gonna take a break and let you do that.
With the court's permission, conduct.
Certainly.
And Ms. Fox, I'm going to announce to you which exhibit it was from the stack. So the one I'm holding up right now is 6W. You would stand right there and tell the ladies and gentlemen of the jury what they are looking at.
This is an x-ray of an infant, and you can see from any distance, you can see the ribs, and you can see that they look like a cage. And they're pretty symmetrical in terms of their alignment. There are no obvious deformities as there would be in a traumatic fracture. But this x-ray happens to show a bulb. This is a ball of healing bone on the 8th, 9th, and 10th ribs on the left. That's too big to be a healing patch and repair for what was not a displaced fracture, because there's no separation. These were just hairline cracks. But the body overproduced the healing bone, which is soft callus. And you can see here it almost looks soap bubbly like, which is characteristic of not having enough minerals in it. So just looking at the x-rays tells me that this is a baby that has metabolic problems, and it's the babies with metabolic problems that tend to have birth-related fractures of their ribs. But there's something else in this x-ray. If you see the teeth, those teeth are primary teeth. Dentists don't see those because those are down in the gum. But they shouldn't look like that on an x-ray. They should look white and hard. But they look like they're shells. And we have a better picture of that later. You can see there's a big gas bubble here in the stomach, and you can see the lungs go down to here, and this is the top of the diaphragm. And this is right in the area where the pancreas is, and that is the 10th, that's the 10th vertebral body that we were talking about.
Ms. Fox, this next one is,
Number 2.
well, I gotta come back. It's 6HH, Ms. Fox.
Thank you.
This x-ray is one of the first things I used to look at when I would look at ribs on an infant to find out whether or not they had an adequate amount of minerals during the process of development. I think anybody can see this even without their glasses. This is the side view, slightly twisted or oblique, and if you look at the ribs coming from the spine and you come out, you can see that there's a flaring, almost like a trumpet, at the end of the rib. Can everybody see that? Where it's expanding. The reason for that is that the bone doesn't have enough minerals. And where it connects with the breastplate, the normal size would fail. So the body compensates for that by flaring the ends of the rib. That's a well-known finding, but it's been neglected and we forget to look for that. But that's called flaring of the anterior or the front of the ribs. This x-ray,
Hold on 1 second. That's 6FF. Go ahead. Go ahead.
again, shows the ends of the ribs. You see how much larger the ends of the ribs are? I'm surprised the radiology reports that I said didn't mention those. Those are important findings. And something that's almost universally neglected is if you see, this is the head of the baby. These are the primary teeth, but they don't look like teeth. They should look like teeth, and they should be solid white with a lot of minerals in them. But instead, there's just an outline, like a ring or a shell. And that tells you that when the primary teeth were being formed between the 16th and 24th week of life in the mother's abdomen, there was inadequate mineralization. Well, if there was not enough mineralization to make those teeth the way they were supposed to be, with a solid top that's very white and dense, then you shouldn't expect that it could do what it needed to do to have normal structure on the bone, because the bone is the reservoir. And the reservoir was running dry, which is why you have this finding on the teeth and this finding on the ribs.
It's 6 double F again.
This is an enlargement to again show you the primary teeth weren't even fully developed. They should have been. And the mineralization is clearly deficient. This is another projection of the ends of the ribs. It shouldn't look like that. And this again is another view of the upper ribs. See how much larger they are at the end? They just expand.
Six double F.
This, again, shows the bottom of the chest and the diaphragm. And on the other side is the pancreas, right up near where that small decrease in height of T10 was. This line that you see here is increased resorption of the bone. That's called cortical tunneling. And that happens when the body is devouring in calcium and phosphorus and breaking it down from the reservoir to reprocess it so that it can manage that increased length that the baby is having during this period of very rapid growth. This is a picture of the wrist, and it's not as obvious, but this also shows evidence of metabolic bone deficiency at the end of the wrist, on both the radius and on the ulna. Again, you see that dark line? That's called cortical tunneling. And that shows that the metabolic activity at the time that this x-ray was taken was very high, and the body was trying to break down the bone to process it so that it could maintain life and growth. This x-ray shows something that I've never seen before. In 50 years, this is the upper arm. This is the humerus. I could point out the cortical tunneling, some of the periosteal elevation, the coarse trabecular pattern, and usually that would go along with the flared rib end and the hollow looking teeth, and that's all you would get. But this case is special. This x-ray almost was cut off, but this shows a piece of fetal bone. That's bone before the baby was born. What does that mean? That means that this blow-up, the baby's, remember the doll, size of the doll, so this is probably 3.5 inches long, but we're blowing it up. So it's a foot. That means that this piece of bone, which is fetal bone, and it's recognizable from this extremity, was present as a reservoir of minerals at the time, because of its size, that the teeth were trying but failing to form because they couldn't get calcium from the reservoir. That means that this x-ray shows profound evidence that's irrefutable. There's fetal bone within the developing but obvious metabolic bone of the right humerus, which it shows that there's a failure of the breakdown of calcium and phosphorus. There's a breakdown of the processing. There's a breakdown of the redistribution of the formation of bone and of growth. I can't tell you whether that is just due to deficiency of the hormone vitamin D, or if it's that in combination with a genetic problem, but this is irrefutable, that the diagnosis of trauma is wrong. This fetal bone confirms everything that I've told you about the ribs, about the teeth, about the failed healing. I don't know of anything that could make it more clear. I've never seen this before. And what will happen? Well, during the 6th to the 16th week after birth.
Your Honor, I am going to ask at this point, we've gone through a long narration. I don't think it's even responsive at this point to any questions by Mr. Hood. I would like, this is his witness, he's going to question and bring information out, but the question was, what does it show? He's answered that, and now we're on a separate narration.
Mr. Hood, your response?
Well, I think it would probably be a prompt time for me to sit down and Ms. Bernard can ask questions and he can resume the witness stand. Is that correct?
Certainly.
So you don't want him to answer any more questions looking at the exhibit?
Not right now.
Not right now, okay. Sir, if you'll step back to the witness stand then. June. Probably heard from you.
All right. Good morning, Dr.
Ms.
Good
Bryant,
morning.
you need to move that. Is that, or you move the podium if that's interfering with your ability to see the witness.
I think it'll be fine, Your Honor. And can you hear me all right?
I can.
Perfect. Well, so I think Mr. Hood has gone through a lot of the same questions that I'm going to ask you about. But I did want to ask, so was there any specific medical trip or work that you did that got you concerned about metabolic bone disease as a factor in human growth and development?
Yes. It was,
Can you tell the jury about that experience?
well, I happened to witness a 1-year-old that stumbled and fell. And his parents reported that he wouldn't walk on his leg the next day. But I saw his fall. He was a clumsy 1-year-old learning to walk, and an x-ray showed an undisplaced tibial fracture. And in evaluating that, that shouldn't have caused a fracture, not even a crack. We discovered that he had a vitamin D deficiency. And that was the stimulus in the beginning, some 20 years ago, of my interest in unexplained fractures in children. Because, of course, his parents were accused of child abuse.
But you had seen the instance in question.
I was an eyewitness to it.
And you mentioned, so we're talking about vitamin D deficiencies. And can you tell us anything about what a normal level of vitamin D would be for an infant?
That's a topic of some controversy in the United States. It's not much of a controversy in the rest of the world, but just recently you may have noticed that the recommended daily minimum requirement for the hormone vitamin D has been raised from 400 to 600. The researchers.
Yeah, I'm gonna object to anything the researchers say. We were not allowed to do
Okay.
that. I'm gonna object.
I have him on cross, Your Honor.
Yeah,
Well,
I would object at this.
I'll overrule the objection. I'm not sure what the rest of his response is going to be. I'll let him respond, and then if there's an objection, I'll hear it at that time, so.
So you mentioned that the recommended level of vitamin D that people should take to be healthy has recently changed from 400 to 600.
Yes.
And so in terms of what is noted as a normal vitamin D level for an infant, is that always actually reflective of enough vitamin D to avoid these kinds of metabolic issues?
It's not just the level of vitamin D, but the question about is that the appropriate level? I think not, because if you take your shirt off and you're exposed to sunshine, your body will convert cholesterol in your skin to 25 to 30,000 units of the hormone vitamin D in about 30 minutes of exposure. There are few foods that we actually get significant amounts of the hormone vitamin D in by ingesting. So I would agree that the level is mistakenly low, but we accept in the United States a level of about 30, but that is probably about half of the optimal level.
So if Jamison Timms had gotten a vitamin D test that reflected a 32.9 result, would you consider that low, adequate, high?
Well, it depends. Part of the problem with the testing of the hormone vitamin D is when it is done, because if a person is exposed to formula or supplements, the level can change in a matter of hours. The bone effects remain for weeks and months. And the bone effects, which vitamin D, the hormone deficiency, is the most likely cause of what we saw in the teeth and the ribs and in the other bone things that I showed you. There's not one test for vitamin D, the hormone. It's a hormone. So it's processed first by converting cholesterol to a pre-vitamin D. That's transported by a special protein to the liver. The liver then works on it and changes it to vitamin D25. That then remains active and available, stored in fat for about 3 weeks. And then, when you need it, the other hormones and guidance send it to the kidneys where it is processed and becomes 125D, which is usually not tested for, but that is the active form. But it's not just a simple matter of looking at different vitamin D levels. It's knowing when they were taken and also the growth hormone level, the parathyroid hormone level, and the calcium level, because these things all work together. Vitamin D, the hormone, works on about 3,000 different biochemical reactions. The most important ones probably involve our immune system.
Okay. Now, you mentioned growth hormone and growth hormone is sort of a powerful stimulant that helps the body grow, right?
It drives everything else.
And so when we're talking about the early weeks of life for a child at 1 month of age or 3 months of age, can you tell us a little bit about the way that growth hormone is impacting bodily processes?
Would you repeat the last part of that?
Can you tell us a little bit about how that growth hormone is affecting bodily processes and how fast or slow things might move?
Well, it's the accelerator, and the pedal is stuck to the floorboard. It's running beyond red line in terms of the metabolic activity.
So are there things that might be different about what are happening in an infant's body versus what is happening in a toddler's body or a young child's body?
Absolutely. But the first 16 weeks are the most critical because of the influence and the stimulus of growth hormone driving the metabolic machinery at the absolute maximum.
Now, you mentioned that sunlight affects vitamin D. So would the fact that Jameson was born in October and scanned in November and January have any impact on vitamin D levels for him or for his mother?
Absolutely.
Just because they wouldn't be getting as much natural sunshine to create that reaction?
It's well known that during the winter months, virtually everybody's vitamin D level, if you tested it, is much lower.
And so would a vitamin D deficiency in the mother impact the development of the child before birth and after birth?
Absolutely, and that's seen in the flared rib ends, but particularly the teeth, because we can time the teeth that they form and are mineralized, the primary teeth, between the 16th and 24th week.
Now, Jameson was born about 5 weeks premature. How would that impact any of this metabolic bone growth?
Well, it's critically important. The things that you consider when you have an infant with broken bones, you have to go through the various things that can cause it. And the very first thing is the osteopathy of prematurity. That means the bone problems that are recognized and known to be a problem in babies that are delivered before their due date. Why does that happen? Because the baby is just not ready. Their lungs have problems, their livers frequently have problems. Most babies get through that period and are okay, and with just time and no treatment, they're okay. But with the bones, the effects last for months. And one of the criteria for identifying the osteopathy or the bone problems associated with prematurity is if they have a fracture. And that puts it in the severe category. So you can't ignore that. The second factor would be anything that would interfere with early mineralization of bone. Vitamin D is by far the most common, but it's not the only one.
Would any medications for blood pressure or anti-nausea that were taken by the mother during pregnancy potentially have an effect on these processes you are describing?
Absolutely. In the records, the mother for a while was taking a beta blocker. Beta blockers interfere directly with calcium. And it's the calcium that causes the problems we're seeing in the bone, not just the hormone vitamin D. The vitamin D you can think of as the messenger from the control center. But it's really the lack of the regulation, the formation, and the adequacy of the minerals that's the problem.
Okay. And what about if there was any trouble with breastfeeding and then there had to be a shift to formula? Would that impact any of these processes you're describing?
It could.
Not necessarily, but it could?
It could.
Okay. What about fibrinogen levels? Is that relevant to these kinds of bone development issues?
I don't know what the effect of fibrinogen level would be. I do know that this case, as in many dozens of others that I've reviewed, the amount of platelets were unusually high. I don't know how to explain that, and I haven't found an explanation for that. But I've noticed that that's an associated finding in dozens of cases just like this.
Okay. So you've noticed it's an associated finding, but you can't say for sure that it has an impact to the jury, just that it possibly could.
Right. It's just associated. I've seen that in the same situation with similar stories.
Okay. Now, when we're talking about this, the T10, the thoracic spine, you're an orthopedic surgeon. What would be your recommended treatment for a compression fracture in the spine?
I don't think I've ever seen a traumatic compression that was uniform and represented less than 2 millimeters in height. So you're asking me about something that I've never seen. But if I were treating a compression fracture, which typically involves nearly half of the loss of expected height, that patient would be in a brace for 12 weeks, and they would find that they're more comfortable wearing a brace that most people would find uncomfortable because of this support, and they would wear it probably day and night for 6 or 8 weeks.
So if there was a compression fracture, which, as you mentioned, usually involves some kind of wedging or asymmetry in the fracture line, why would that brace be important?
Well, it keeps it from further compression or stress on it. It protects it during the period of healing.
Now, what about the impact of a genetic variant on the COL1A2 gene? Would that potentially have any impact on the bone development processes?
Object, he's not a geneticist. We established that when I asked him questions. I'm going to object to anything that a geneticist would be qualified to answer.
Ms. Bernard?
And Your Honor, we do have geneticists coming in. However, he has been qualified as an expert in both orthopedic surgery as well as metabolic bone disorders, and genetics are a factor that he has studied and considered in the course of his extensive career in medicine, multiple hospitals practiced at, many cases he has seen.
Your Honor, I've been very expansive with what they're allowed to do. It's gone well beyond orthopedics into the different subsections that I do object on genetics, he's not a geneticist.
I'll overrule the objection. I'll let you ask the question, and then he can respond if he knows the answer or not. So-
Certainly, and only respond with the appropriate level of confidence based on your training, experience, and education in the area.
Can I give you a brief synopsis so we know what we're talking about when we talk about genetic testing and COL1A1 and COL1A2?
Yes, if that's from the basis of your knowledge, training,
Yes.
and experience, then yes.
So, as I understand it, every cell in the human body, except for red blood cells, has a control center. We call that the nucleus, and that's where the DNA is. The DNA has 23 pairs of chromosomes. Those are protein strands. They have more than 20,000 genes. Those are proteins that have sequences, and they control hormones.
This is clearly genetics and not orthopedics.
Well, and we do have a geneticist who will be coming in later. You know, we did have to call you a little out of order, Doctor. We had intended to have the geneticist first, but had to call him out of order. So
The question, I mean, I'll let you ask if he's had training in this. I mean, I understand he's not a geneticist, but, I mean, there is a lot of other types of training that go into be a medical doctor. And, I mean, I think he's getting to his answer. I mean, if he has to rely on these other levels of training to form his answer that he does in his orthopedic practice, I'll let you ask about that. Now, he can't just, do a monologue of something in the medical field, but if he can form his answer based upon his training and experience, I'll let you ask the question.
So thank you very much, Your Honor. And so if we can try to tailor it a little bit to the mechanism by which a genetic variant might impact the metabolic bone processes that you are describing and have so much experience in.
We're almost there. So there are about 20,000 codons, and several hundred of those are involved in bone and collagen. 2 of those happen to be named COL1A1 and COL1A2. Those are known to be involved in the production, the organization, the distribution, and the architecture of collagen that makes up our bones. Those 20,000 codons, of which several hundred involve bone and collagen, only 2 of which we're looking at, the COL1A1, COL1A2, they control 75,000 enzymes that turn on, turn off, speed up, and slow down the 1 billion biochemical reactions that take place in each cell of our body every second.
Still talking as a geneticist, he did not tie this to the bones at all. And they said they have a geneticist comment. I think this particular line of question is more appropriate for the geneticist.
And Your Honor, he did specifically say that COL1A1 and COL1A2 are related to the collagen development in bones.
I'll overrule the objection. I'm going to let him answer that question. He certainly did say that.
Thank you, Your Honor. You may continue, Dr.
So at the 17th level, the COL1A2 is looked at. When you send blood off and you say we'd like to do genetic testing for osteogenesis imperfecta, they look at COL1A1 and they COL1A2. There's 1,366 proteins involved in COL1A2. So they look at a zipper and they know what it's supposed to look like. If there's a section missing, or if there's a duplication of a section, that's an anomaly, that's an abnormality. In this case, they said, we found this anomaly.
Next to what they say at this point.
And
Okay.
if I could direct the additional question.
Okay, I tell you what. I'm gonna ask the ladies and gentlemen of the jury to step to the jury room, please, for a moment. Ms. Bernard, you can continue with your questioning.
Thank you, Your Honor. And thank you, Dr. If you could continue your discussion of the relevance of the call 1A1 and call 1A2 genes to the metabolic bone processes that you've previously described for the jury.
Okay, we had just discussed that the col1A2 is known to be involved in the collagen and bone formation, breakdown, reabsorption, and structure.
So would the existence of a variant on that gene tell you anything about the possibility of disrupted metabolic bone processes?
It tells us that potentially that could help identify a group of 8 conditions that are known to involve collagen problems, either the adequate formation or quality or organization. Those are called osteogenesis imperfecta. And those 2 sites, the col1A1 and the col1A2, are the names of those 2 sites, which are known to be involved in some cases of osteogenesis imperfecta.
And can you define osteogenesis imperfecta for us? I know it is a broad term.
It's quite a spectrum. It's a group of 8 conditions, from very mild to almost insignificant in terms of the number of fractures that a person might have, to the most severe that might have over 100 fractures in their lifetime, and they may have a dozen or 2 dozen fractures at any one time. So there's quite a spectrum in terms of almost no observable abnormality in terms of the structure or function of the bone or the appearance, to one that are prematurely lethal. Some osteogenesis imperfecta patients are very short, have remarkably short arms and legs, have an unusual conformation of their chest. It's kind of barrel-shaped. They have kind of a triangular appearing face. They tend to have associated early deafness. They are likely to have scoliosis or kyphosis and spine problems. But then some of them that fit the clinical criteria, where anybody that had seen a group of patients with osteogenesis imperfecta would say, that's one. The test cannot confirm it.
So do some of the individuals who have some form of metabolic bone disorder, do they always have long-term problems? Or is it something that ever resolves or changes throughout the child or adult's life?
Some of them, the deficiencies, can be temporary. And after a year or 2, the development is normal and as expected. Even some of the genetic problems, which the severe cases, many of them die before birth, and many of the rest die very early in life. Maybe half of them will die within the first year or 2. The ones that survive, their bodies seem to be able to compensate, and many of them live a near normal lifespan.
So, given what you have examined about the case of Jamison Timms, would there be anything, what would you say if he had not had any more fractures on the rib or any other findings in his skeletal surveys?
after 16 weeks, the stress of extremely rapid growth diminishes. So that's the period when they would be most vulnerable. After 1 year, there's even less growth hormone driving the metabolic machinery. So most likely, he would not have any more fractures or be more susceptible, in my view, than patients that didn't have this.
So just to be clear, if Jameson did not have any additional fractures, would that change anything about the testimony you have offered regarding the appearance of his skeleton in the first 16 weeks of life?
No.
Are you able to tell what specific deficiency might have existed in Jameson Timms in his early life?
No.
And you have consulted on cases all over the world and all over the United States, correct?
I have.
And you have practiced at 15 hospitals in your career, is that right?
That's right.
And you've practiced in 8 countries around the world?
Actually, I've been in 10 countries, but I've actually operated in 8.
So you've actually operated on patients.
Right.
And this has included patients who have suffered trauma or unexplained fractures or a variety of factors?
A variety of things.
Okay. And have you found instances where fractures are the result of trauma?
That's the most common thing I do, is I take care of people that are traumatized.
So you have found a lot of x-rays that do show evidence of trauma in the course of your career, is that right?
That's right.
Okay. And do you consult on these cases of unexplained fractures for pay or pro bono?
I've always done it pro bono.
So it's not like the Timms paid you a bunch of money to be here and give this opinion.
No, this is an inconvenience for me and an expense. I pay my own way.
And I believe you were on a vacation with your grandchildren when you flew in to see us for this trial, is that right?
That's right. I got here from Maui at about 8:30 yesterday morning after flying all day and all night.
Okay. So do you have any reason at all to give an opinion on Jameson Timms' medical records other than the honest belief of your experience and training for almost 50 years?
It is 50 years.
50 years. Well, so would there be any reason for you to give this jury any opinion other than what your honest training and experience tells you about the situation with Jameson Timms?
I don't know what it would be.
Okay. Well, and the images that we have used as demonstratives, did you get these from the radiological scans that were provided to you from Children's Hospital and Erlanger and the other places that had done skeletal surveys of Jameson Timms?
Yes.
And the only change is that we have blown them up to be larger, correct?
That's right.
But otherwise, they are an accurate reflection of the x-rays that you viewed on the original, I think it's called the DICOM program, that allows you to really zoom in and see all the details on a radiological scan?
They look the same.
Okay. Your Honor, at this time, I would tender defense 1 through 9 into evidence.
Okay, and where are those documents? Or photographs?
Yes, we accidentally printed 1 duplicate. So
Okay.
we only have.
Any objection to defense 1 through 9?
No, ma'am, they showed them to me yesterday, and we compared them to the originals. They're blurrier, but they
Okay.
are what they are.
Mr. Hood, any objection? No objection. They'll be admitted.
Thank you, Your Honor. All right, thank you very much for your time, Dr. The state will have a few questions for you.
Ms. Fox?
Is that one of y'all's folders?
Yeah. Do you want me to move these?
I'm gonna use one, and then, yeah, we'll put them behind the core for her. Thank you.
I want to just use what's marked as state defendant's exhibit number 9. I'm going to turn it towards you. You don't have to come down again. But I do believe this is the exhibit where you indicated that you could see the rib fractures in this particular case on ribs 8, 9, and 10.
That's not the image that I used to point those out.
Okay. Well, they're there, but.
They are there. I think that one would show it, yes.
There on
Yes,
8, 9, and 10.
that's right.
In this particular setting, as an orthopedic surgeon on a baby, you wouldn't have provided any casting or anything for broken ribs, would you?
Those are old fractures. They're not unstable, so no treatment would be required.
Okay. And then you also indicated that on this, you could see the compression on T10.
You can,
And that you also measured it, I guess, against the Erlinger to note that it was a 2 millimeter compression.
at the most.
Okay. And I take it from what you were trying to explain to the defense attorney is there would be no treatment for a 2 millimeter compression. You would not have started bracing unless it was at least half the height, which in this case would have been at least 4 millimeters or 5 millimeters.
That's mostly true. It wouldn't have to be a depression of half, but 2 millimeters or less than 2 millimeters is insignificant structurally, and I wouldn't have required any treatment.
So if there was no treatment done for Jameson in the way he was presented on January 14th with these healing injuries, you would not have found that to be medical malpractice on the treatment team because you wouldn't have done anything different yourself.
That's right.
Okay.
What sets of x-rays were actually provided to you? I think I noted that you were using x-rays from the January 14th CHOA scan, and then you had referred to at least one from the December 8th Erlinger scan. Did you receive other x-rays?
I did.
Did you receive the reports that went with those x-rays?
You know, I don't know that I got all the reports. I had some of them, but I received the electronic medical records.
Would you not have wanted to see what the real radiologists, the ones that had gone to school and been trained, had thought of or found on the scans that you were also reading?
Well, I'd especially be interested in his failure to comment on the teeth and the flared rib ends.
Okay, so we'll get to that in just a minute. So you would have liked to at least see what the radiologists have written?
Yes,
Okay. You did get some records, I think, from CHOA at least, the medical
I did.
records. And in that, you noted that you thought the platelet count was actually elevated.
it was.
At CHOA, on page 285 of the record, or rather on page 200 of the record, it was at 285. 285 is not an elevated platelet count, is it?
No, but
In fact-
that's not the one I was referring to.
The range is 15 to 450, so it's smack dab in the middle, correct?
That's right.
So his platelet count on some of the records was well within normal.
That's right.
The platelet volume, which is also important, was also normal, wasn't it?
I believe it was.
And that is another factor that you would consider when you're looking at those issues, correct?
Yes.
You indicated that one of the things you noted was his, and I want to say it correctly, is it lipase?
Lipase.
Okay. You noted that both in the CHOA and the follow-up at CHOA, it was remarkably low in your opinion.
I noticed that.
And then, did you note in the Erlinger records that it was non-concerning at Erlinger as well?
I don't recall that.
Okay. One of the things that you had mentioned is if you had significant trauma, you would expect the lipase to remain elevated for about 2 weeks.
I would.
And then after that, it would necessarily come down.
You'd expect it to.
Okay? Is this a fair statement here? After trauma, lipase levels can remain elevated for up to 2 weeks, depending on the severity of the pancreatic injury, typically peaking within 24 hours and gradually returning to normal over time. Is that a fair medical statement of what lipase does in the body?
That sounds right.
I'll add one more thing. If there was significant pancreatic damage, it could be elevated a little bit longer. I think that would complete that whole analysis on what lipase is, isn't it?
I'd expect that.
Okay. So if his lipase is low in January, you would expect the injury to at least have happened 2 weeks prior to his presentation at CHOA, correct? On just that one factor, if you're just looking at lipase.
If you just looked at that one factor.
Okay. You've actually issued 2 separate reports on this case, haven't you?
I did.
Your first report, you talked an awful lot about EDS, Ehlers-Danlos syndrome.
That's a collagen problem.
You didn't mention it at all today.
I didn't.
Did you find out in the meantime that babies can't be diagnosed with EDS?
I think that misrepresents my report. I think, as I recall, because it was 2 years ago, actually almost 3 years ago, when I initially provided a report, I think there was a family history that suggested that someone in the family may have had that. Okay. EDS is a collagen problem.
So if a doctor will testify later that there is no EDS in the family, then that's a non-factor.
That wouldn't change my opinion.
Okay. In this particular situation, in your first report, you also talked about craniosynostosis.
Pardon me?
Craniosynostosis.
Craniosynostosis.
Okay. You spent an awful lot of time talking about that. You did not mention it at all today, did you?
You know, I do recall that there were other bone factors, including the skull, which is craniosynostosis.
Right.
That happens with some of the things that we talked about that you have to consider as a possible cause of metabolic bone disease.
And one of the things that you said in your original report is you felt like Jameson's fissures had closed too soon.
That's what craniosynostosis is.
Exactly. But it didn't, did it? He has a beautiful shaped head.
I haven't seen him.
In fact, the pediatrician had checked routinely for the soft spots and the fissures and found that he was on track normally.
I never saw those records.
If you have that condition, the treatment is to wear a helmet as a baby, isn't it?
Sometimes it is.
And if it's untreated altogether, the head comes elongated. You almost...
That's in exceptional and extreme cases.
You get a ridge too, a noticeable ridge when they join too soon.
I have never seen that.
Okay. But you didn't talk about that today. You
I
don't
didn't.
find that to be an important finding after all?
No.
Okay. Do you know that temporary brittle bone disease is actually a hypothetical disorder?
Well, any deficiency that causes weak bones that can be corrected by replacing what is deficient would be temporary. So I don't think that's, I think that's an accurate description, just as a more permanent bone condition would be one that has an enzyme problem such as hypophosphatasia or hypophosphatemia. I wouldn't expect those to get better because those are genetic flaws, and so the flaw stays. You can't correct it. You can't change the genes.
Would you agree that the medical community views temporary brittle bone disease as an unfounded and unreliable diagnosis?
Well, I think there was a man who studied some 200 cases that wrote a paper that was entitled Temporary Brittle Bone Disease.
And that man was Colin Patterson, and he lost his medical license over the paper he wrote, the testimony he was giving in courts regarding that, didn't he?
He did, but a review of his records And in the context of today, I understand that when he looked at those 200 cases, he didn't have a commercially available vitamin D, the hormone test, and he confided in me that he thinks the vast majority of those cases were vitamin D, the hormone deficiencies.
So he told you that before he died, so you're the one that knows that then?
He did die after that,
Yeah.
but he was an old man like me.
Okay. You're saying that vitamin D is a strong consideration in this particular case?
Pardon me?
You're saying vitamin D deficiency is a strong deficiency in this particular case?
I said it's the most common. It's the most likely.
Did you review the medical records from CHOA that showed that his vitamin D was 32.9?
I was aware of that.
Did you see that the range was anything below 19.99 would have been considered low?
I'm aware of that.
So his vitamin D on the test that he was given was well above what would have been considered low on January the 14th when he was presented at CHOA.
Yes, but what I said was the bones and the ribs show irrefutable evidence of an early inadequate bone mineralization. Doing the test weeks and months later is of no significance. It's just confusing the issue. You can't do away with the findings that are objective and real.
But the finding that is objective and real is he doesn't have a vitamin D deficiency when he is presented at CHOA on January 14th, does he?
On that date, by their criteria, he did not. But the
Well, even-
x-rays show otherwise early in life.
Even if we use your criteria, you said 30 would have been the cutoff. He's still above your cutoff
That's
of 30.
I would say that 30 is still too low, but I don't know that there's any way to extrapolate back from several weeks or months of blood test to bone findings that are irrefutable and are clearly related to inadequate bone mineralization.
Are you familiar with the article, Rachitic Changes, Demineralization, and Fracture Risks in Healthy Infants and Toddlers with Vitamin D Deficiency?
When was it written?
2012.
Who was the author?
Jeanette Perez Rosello, Henry Feldman, Paul Kleinman, Susan Connolly, Rick Fair, Regina Myers, and Catherine Gordon.
Doesn't sound familiar.
But your study in this area, you're self-taught, and that was an interest that you developed about that time where you started researching on your own, correct?
That's right.
Although it is true that some babies have broken ribs in childbirth, isn't it also true that those babies were particularly large?
No, that's not true.
Did you know that Jameson was actually a small baby?
Yes,
5 pounds and a few ounces.
I was aware of that. He was premature, which gives you a risk factor of the osteopathy of prematurity. You can't ignore that.
You indicated that you would have liked to have seen the radiograph reports that were written by the certified radiologist in this case.
I wouldn't brag about his certification since he missed the teeth and he missed the ribs.
Okay, well, there were several. Were you given the report from radiologist Nicholas Appleton from Erlanger on November the 18th of 2021?
I don't recall it. I'd be happy to review it.
From the bottom of this page, and goes to the top of the next.
Is this all he had?
That was the report we were given from Dr. Appleton.
He didn't make any mention of the teeth or the flared rib end,
Yeah.
or the abnormal callus
And he didn't see
of the
any
rib.
fractured ribs either.
No, he didn't,
Did not see a compression injury.
but he's certified.
And that's November the 18th from Erlanger. Were you given the outside study? That is, what is an outside study?
Well, that just means outside of that hospital, it means a different hospital usually.
So you take the x-rays that the hospital at Erlanger does and you send them to a totally different hospital to be read.
That's right.
Were you given the outside study on the November 18th skeletal surveys that Dr. Khan did from the Texas Children's Hospital?
Was there a question?
Yes, I'm asking, were you given that report?
I don't recall. I did most of the medical record reviews 3 years ago.
Okay. So that report does not show any fractured ribs or compression fracture?
No, he doesn't mention the teeth or the flared ribs either.
Show any metabolic bone disease?
He didn't mention it, but it's pretty clear on the x-rays.
Okay. Were you given Dr. Coleman's report from December the 8th of 2021 from Erlanger?
I may have, but I don't recall.
Just refreshes your recollection if you'll glance through that and tell me if that's one of the ones, because you used at least one of his films. And Dr. Coleman did not find any evidence of metabolic bone.
Oh, he did.
Well, the periosteitis that he, go ahead, and you can answer it first, that's all right.
Well, he did, but he didn't recognize, he recognized the bone findings. He said that there was periosteal reaction. That is a known finding. I could have shown you that on the x-rays, but I didn't think we needed to.
If he testified and told the ladies and gentlemen of the jury that it had resolved, that would not surprise you?
It wouldn't surprise me.
Okay. He did not find any of the other findings that you just told the ladies and gentlemen of the jury.
No, he somehow missed the flared rib ends and the teeth.
And he actually said there was no fractured ribs?
Well, I didn't hear him say that.
No, in the report.
Yeah,
No fractured ribs, no compression fracture on December the 8th.
well, he may have been using a different monitor than the other radiologists. You know, there's a lot of difference in the quality of the resolution.
Were you given Dr. Paula Dixon's report from January the 14th?
Again, I probably had it, but it's been 3 years.
So I've got the 14th here. This would be from the 14th. My question is, were you given that radiologic report, radiographic report?
I assume I was, but I don't have any direct recall.
Okay. There's no mention of metabolic bone disease in that report,
No, they all missed it.
but she noted the 3 broken ribs, and her language on that date was T10 was suggested a compression fracture.
He didn't describe the failed healing and the unusual large ball of callus either, and the soap bubbly appearance in the rib at 10.
Were you given Dr. Paula Dixon's February 3rd, 2022 reading of the x-rays that were taken on that date?
Same answer. I may have had it, but I don't have any direct recall. But this is a claim of a compression fracture of T10.
So, states the compression fractures there, no longer can see the fractures on the ribs.
Well, he didn't see him on that x-ray, but if you depending on the rotation of the x-ray, you won't see them.
On February 3rd,
That's right.
2022.
On any date. If you have rib fractures and you rotate the x-ray, you may not see them.
No mention of metabolic bone disease.
Well, the omission is obvious.
Were you given the outside reading of the January 14th, 2022 X-ray from Texas Children's Hospital by Dr. Amy Maholan-Ray?
Again, if I had it 3 years ago, I don't recall that. The impression says there's a healing posterior rib fractures involving the 9th and 10th, possibly the 8th, and the T10 compression fracture, but they failed to describe the failed healing or the nature of the minimal loss of height of T10.
So Texas Children's Hospital doesn't talk about metabolic bone disease either, do they?
They just didn't recognize it.
Were you given the report from pediatric radiologist Carrie Braithwaite from June the 16th of 2022?
Same answer.
Let you look at it and see if it looks familiar.
You have a question?
Yes, my question is, were you given that report?
Again, I don't recall whether I had it 3 years ago. I think I probably did. I go through all the records.
In June of 2022, no fractures are noted.
Doesn't have any fractures. He also adds that he thinks that there was evidence of abusive, said his original injuries are consistent with abusive head trauma.
That's not that doctor's report, that's a note above it. The actual report is by Carrie Braithwaite.
Oh,
And Your Honor, at this point, I would ask, is the state intending to call any of these doctors to which it is
I'm asking.
introducing reports and discussing?
I have
Okay,
one
but-
more question along these lines. I'm
Okay,
asking if
well,
you're.
well, wait just a minute. Let's get a response to that question first. So are you, these reports, are you calling these folks as witnesses?
I've already called Dr. Appleton, I've already called Dr. Coleman, I've already called Dr. Dixon, that's 4 of them.
Okay,
My question is, did he get all those reports? Because I got 2 of them from the defense. I'm just asking if he
okay.
got them all.
Well, I think go ahead.
Yes, and so, Your Honor, we, obviously, the individuals who have already testified to the jury, we've got no issue. You know, these are big medical records, the witness is answering honestly. But at this point, the state is making inquiries and showing reports of individuals that they have never brought before this court. And I don't know if they have any intention to make these individuals available for examination. And so that would be my objection, is if they are going to refer specifically to the names and findings of doctors that they believe are introducing evidence, they need to bring those doctors before the court.
So you have no objection to the doctors who've already testified that Ms. Fox just referenced?
Oh, of course not.
Okay, so which report specifically do you object to? Which one is it?
Well, I think this last one from a Dr. Braithwaite, and then the previous one from a Dr. May, perhaps. These are not individuals who have been brought before the court, and my question is, are they going to bring these individuals before the court before they cross-examine our expert witness on the specifics of those reports?
Ms. Fox?
State is not going to call those witnesses at this time. I have one more question regarding whether he got those reports. My
Well,
question is whether he got them.
You can ask him if he got them, but you can't ask him about something in the report if those folks are not going to testify.
Thank you, Your Honor.
Bottom line is, when you received the file of this particular case, you indicated you had reviewed it. Correct? The medical record. You said you reviewed the medical record.
I did.
You don't remember which radiological reports are in it or not?
I don't.
You don't think it was important to know what the real radiologist said in regards to the scans that you've just testified about? And Your Honor, that's my last question on this line.
I didn't say that. That mischaracterizes what I said. I'd be interested in what they said. I'd be happy to show them what I found, and I think I could convince them that their reports are deficient and that they missed the most obvious findings on those x-rays are the ones that they never discussed.
Right. And you're not a radiologist.
I'm not a radiologist.
Okay. Are you familiar with the article Evaluating Young Children with Fractures for Child Abuse? It's a clinical report.
When was it written?
February of 2025. Actually published in January of 21st of 2025.
No, I haven't.
So you didn't read
I didn't
that
read
particular one? Okay. Would you agree that even children with metabolic bone disease can be physically abused?
Of course.
Your Honor, I have no further questions then.
Mr. Hood, anything on redirect of your witness? Ms. Bernard, anything of recross on this witness?
Has anything changed about the opinion that you have rendered regarding Jamison Timms and his condition based on the questions that you have just received?
No.
Do you believe that there is any chance that there was inflicted physical trauma on Jamison Timms as a result of the radiological scans and evidence that you have viewed of his state?
Absolutely not.
Thank you very much, Doctor. Please enjoy your time with your grandchildren.